I'm Nagesh, the editor of Healthcare Radius, and I thank you all on behalf of Healthcare Radius and ITP Media India for joining our webinar on remote patient monitoring, addressing India's healthcare accessibility challenges. Healthcare Radius is a B2B monthly magazine and a website from ITP Publishing Group, a powerful business intelligence tool that helps all stakeholders in the healthcare industry to grow and improve business practices through relevant information. Now, let me introduce our esteemed panel for today. The moderator for today's session will be Joy Chakraborty, who is the Chief Operating Officer at PD Hinduja Hospital and Medical Research Center. Passionate in nurturing new ideas and thoughts for experiments in healthcare delivery, his responsibility includes ensuring optimal capacity utilization of hospital resources, managing operations, and implementing the hospital's business strategies. He joined PD Hinduja Hospital in 2007 as Deputy Director for Administration. A known face in the industry, Joy has also held the position of Chairman of Healthcare Initiatives at CII Western Region. As mentioned earlier, he is going to be the moderator for today's session. Thank you, Joy, for being on the panel today. Our next panelist is Dr. Swapnil Madhav Khatake, who is the Chief Intensivist at Fortis Hiranandani Hospital, a prolific author with numerous international publications with expertise spanning across the areas of airway management, mechanical ventilation, cardiac output monitoring, sedation and pain management, enteral and parenteral nutrition, general and regional anesthesia, continuous renal replacement therapy, extracorporeal membrane oxygenation, and management of polytrauma. He is the founding member of Nephrocritical Care Society established last year. Thank you, Dr. Swapnil, for being on the panel today. Our next panelist, Aravind Ganesan, is the group head for digital strategy at Kauvery Hospitals, an IIM Bangalore alumnus. He has over 17 years of experience in digital product development and product engineering for strategic initiatives in healthcare for providers as well as payers and automotive industry across India and North America. He's implemented and managed customer-facing digital products, big data engineering and analytics platforms, remote patient monitoring systems, and CRM systems right from product conceptualization to post-implementation operations. Thank you, Aravind, for being on the panel today. Our next panelist, Dr. Sanjith Saseedharan, is the Director of Critical Care at SL Raheja Hospital. Dr. Sanjith has completed fellowship in neurotrauma critical care at University Teaching Hospital in Israel under the mentorship of Professor Charles Wiseman and Charles Sprung. He is the only Indian doctor to hold such a specialty in India. Under his leadership, the ICU facility at SL Raheja Hospital utilizes technologies such as FRC calculation and transpulmonary pressure for mechanical ventilation, as well as indirect calorimetry and functional hemodynamic monitoring for optimal patient care. Dr. Sanjeev has a patented software to his name in the field of critical care nutrition and has received Best Innovation Award for technological patient interface called Vocalizer. Thank you, Dr. Sanjeev, for being on the panel today. Now I am handing over the reins to Joy Chakraborty, our moderator. Over to you, Joy. We can get started with the session. Thank you.
Thank you, Nagesh, and thanks to all the esteemed and distinguished panelists for joining here today for a very, I think, interesting and pertinent topic of remote patient diagnosis and monitoring. I think Nagesh has done a very good, beginning by stating the need of the hour of Indian healthcare, that is getting accessibility done. I think in my 26 years of healthcare industry journey, I think we are talking about this making healthcare accessible, affordable again and again and again, but very limited number of, I should say, the success or achievements what we have made so far to really ensure that accessibility has improved over a period of time. But let me tell you, though it was a big challenge during this COVID, we have undergone a tremendous transformation in Indian healthcare, and that has led to a situation where we have learned many new technologies, new things, and one of those is this remote patient monitoring and diagnosis. And I'll not say that is the only time where you have used, but I think that has given a huge momentum. And that momentum is required for multiple reasons today when we have 65 to 70% of population staying in rural areas, when our doctor is to patient ratio is very less. At that juncture it becomes very important that how do you reach out to maximum number of people with available limited resources. And probably this remote patient diagnosis and monitoring is going to help us in that endeavor where an early diagnosis can help, and at the same time, a person for whom the healthcare accessibility was a dream that can become reality. So, with this background, I think I'm going to start with my esteemed panelist, and I have with me Dr. Swapnil Khatake. I think he is there in the panel already. So my question to you is that why do you think that remote patient diagnosis and monitoring is critical for India's context today, and how does it benefit our patients for whom all of us are working today? So over to Dr. Sapnil.
Thank you. Thank you very much, sir. And thank you everyone for making available this platform for such a futuristic approach to our patient care. My point is, whenever we are dealing with this patient care monitoring in remote places where it is very difficult to access physically, but if patient is difficult to transport or in earlier stages, if patient has to be uh, targeted and particularly when we say is a sepsis. So concept is hit hard, hit fast. In same way, whenever we are dealing with the patient or we are getting access to the patient in remote cases, in that case, monitoring and obviously equal accurate diagnosis and timely decision making will be something which can help patient improve without transportation to higher center. Other than that, our peripheral healthcare system will get strengthened with the availability of remote ICU or patient care monitoring with the help of tertiary care centers, particularly if you are dealing with, for example, I'm having my all the setup in Fortis Washi. With that thing, I can obviously can target all the peripherals along with my territory, particularly in Navi Mumbai, I'm saying. Now, many of cases, whenever if you are losing important time in initial phase, day one, day two, or before that, then patient might get deteriorated and patient might not be able to get transported to tertiary center. Other than that, many of times financial things can be beneficial in when we think of patient. We still have lots of non-insurance patient or non-reserved patient in terms of paired one. But if patient is getting managed at their lower center, I mean to say peripheral center, definitely finance wise, it will be much more benefit to the patients and they might get better without transportation to tertiary center. Now, catch here is when we are having such centers, I mean to say peripheral centers, catch here is the staff working on ground level, including doctors or the nursing staff or the RMOs or the nutritionist or dietitian or all the housekeeping staff. They should be equally competent to execute our plans on ground level. Other than that, they should be equally competent to have better communication with the physicians on ground level and to the remote level who are monitoring from their own setup. All this thing to be communicated with relatives also. If this chain is functioning at its highest level, definitely we will be able to save more patients, more time, and the timely decision making with accurate decision making we can always achieve. Now, thing is that problem or the limitation could be the legalities or the responsibility. Whenever we are dealing with these medical legal issues, any problem, I mean to say relatives or patient's condition, every time we have to be clear with consent or probably informative informed consent or the proper explanation by the ground team and team who is seeing the patient or monitoring the patient or taking decision. on the screens. I mean to say remote setup. In this particular setting, we always have to explain and have good communication with primary team and on ground level that whatever they are getting suggestions from this remote team or who is tertiary center team is managing the patient is always based on all suggestions, whatever they are saying or whatever they are advising. But all the medical legalities or the responsibility belong to the nursing home setup or the ICU setup who is in periphery, who are taking help of this tertiary center. That thing should be well communicated with the hospital, with the owners and the relatives. So by this thing, after understanding at every step, then this model should get benefited to patient and all the centers and all the healthcare. My point will be the ground staff should be equally competent to execute the plans and after discussion, whatever we are taking the decisions, and they should be equally competent for the communication to the physicians on the remote setup, on ground level physicians, and all this to be executed at ground level and the discussion and communication with the relatives. That's what my point is. But yeah, definitely our future oriented approach is important and it is beneficial to our healthcare and lots of peripheral patients in terms of strengthening the peripheral healthcare system with the help of all these remote centers. Obviously, we can have our survey and our advice to these centers that whatever instruments or whatever logistics we are requiring, that we have to get established or they have to establish by themselves. I think there should be some business model to grow by everyone and should get benefited to patients with some financial benefit. That's what my point is.
So thank you, Dr. Swapnil, for a very comprehensive, elaborated description of your point of view. And I think what is coming and echoing in your words, 60 years back, India had got a report of a committee called Vore Committee in 1963, and they tried to develop a tier-based healthcare delivery system like a pyramid where we had lot of primary health center, the smallest kind of unit in the bottom, and that was converging into the tertiary care center. So Dr. Sapnil was talking about the same kind of structure, that how it can get strengthened. Then I'm sure, so a country like India with 1.4 billion population, where reaching out to each and every individual is very difficult, I think an approach like this will be very, very essential. And secondly, he has touched upon one very important aspect, that is the skill of the professionals who are going to deal with this. I will come back to that little later, but I move on to my next clinical practitioner part of my this panel, Dr. Sanjith Saseedharan, the consultant and head critical care SL Raheja Hospital. My question is, very often we come across the situation whether anything and everything can be brought under this remote diagnosis, monitoring, and that kind of situation. So the question is, what are the common illnesses? What are the common kind of, diseases? What kind of common situation we should aim to cover under this particular, platform? So over to Dr. Sanjit.
So thank you, Dr. Joy. And what the question that you asked is an actually most pertinent question in this discussion, to know which is the target group that we would be targeting here. Now, I would put it into two baskets. The first basket would be general medicine, and the other would be chronically critically ill. There are two categories I'll put it as. So one of the main important things that we must all understand is general population also. General population actually requires remote monitoring. When I say general population, why am I talking about? I'm talking about those who are elderly. Mind you, India is a country where the younger population is reducing and the elderly population is increasing. Not only that, because most of the healthcare is in the in the cities, and most of our young adults are actually migrating to cities and seeking jobs abroad. The elderly populations are alone at home. Many of them are alone at home. And this is that population that lands up into the intensive care unit. So that kind of population needs to be monitored not only for diseases, but also to one of the most important aspects, which includes frailty, which includes falls, things like that. So one of the simple things that you can monitor in such cases is the incidence of falls. What usually occurs is these patients fall at home, they are not, or they have a stroke or something like that, and then they land up into the hospital much later than when we could have actually taken them and given them some kind of meaningful benefit. Now, this kind of monitoring systems could be actually targeted to these elderly population. Now, many systems abroad have already started doing it on this on a regular basis, where elderly people wear wearable devices and they detect these kinds of falls. The other problem when you have older individuals is chronic disease status. Now, chronic disease status like diabetes and hypertension is another very important. Remember, we are the third highest populous country when it comes to diabetes. So diabetes and hypertension, these are two remote monitoring that can be used on a regular basis, because what happens is that the sugars that they monitor are conveyed to them nowadays on a phone call. Now, the doctor who is on phone will probably receive it and then may or may not answer it, or may not receive the phone call itself. So when you have remote monitoring, the moment they do a sugar, by Bluetooth connectivity, it comes to us. We are able to actually put up, and I don't think we should have that human engagement also there. There are nowadays algorithms are very clear. AI should learn what insulin should be given to this particular patient, and that should be actually relayed back. This is what remote monitoring will be. In monitoring, I will only monitor, but the treatment will be decided by deep learning and AI, is what I feel with respect to this. Similarly, when you look at hypertension, it will actually tell us that the blood pressure is going higher and higher, and so we need to alter it, giving us kind of an alert to the doctor. So there has to be some kind of alert systems which will be targeted, personalized to that particular patient, that will help these individuals, so that we can get them much before they go into an accelerated hypertension rather than hypertensive urgency. The third thing that I would say is chronic critical illness. See, what is happening now in acute care, we are actually trying to save many patients. And because of the improvement in technology, we are managing to do so. We are actually saving a lot of more patients that we would have earlier done. Initially, the sepsis mortality was at 45-50%, and now it's come down to 28 and 30%. That means on an average, we are saving thousands and millions of lives back to home. But what is important is they go home, but almost 15% of them die in the first year, and almost 45% of them come back to the hospital within the first 3 months. I mean, so many times we have those difficult to treat patients that have gone home and then come back. Right now, as I'm speaking, we had a patient that we had shifted home 15 days ago and has now come back to the hospital for a problem that I could have treated right from here. Right from here. For example, simple things like vital monitoring. What happens is when you send them home is they do episodic monitoring, once in the morning, once in the evening, and they don't really get back to us. And what happens in the middle, nobody knows. Now, this particular patient, if this was monitored on a routine, continuous basis, we would have his pain points ready, that he's had an arrhythmia, or and I would check an electrolyte imbalance. That electrolyte imbalance could have been treated at home, need not have come to the hospital. And this patient, we could have saved that amount of costing that this patient has, the problem that these patients' relatives have. So I think chronic critical illness is something also that needs to get back, because we have a very high proportion of patients that are getting discharged from the hospital, but not functionally independent to report back their problems that are coming to us. So that is another big population that needs to be tended to, especially because the mortality in that patient is very high. We're talking of the real critical care patient that has been shifted home. We don't have these mid centers in our country where we can actually move them to a facility and then wait over there. Unfortunately, most of our patients, if they go to such a facility, they have institutionalized death. They die much quickly in those centers. So I would put it this way, that we need remote monitoring for these kind of patients also. Another category of patients that will benefit is pregnancy. If we can monitor the fetal monitor on a regular basis, these patients need not come to the hospital and expose themselves to all the problems that occur in a hospital, which includes airborne diseases and TB and things like that. So these pregnant patients, they also feel very comfortable if their fetal heart rate is monitored, if their BP is monitored, and some doctor gets back to them with respect to remote monitoring. I think pregnancy, sugar, blood pressure, and I think fetal monitoring will make a very big impact and save maternal mortality as well as fetal mortality.
Thank you, Dr. Sanjith. And I think 20 years back, India had the burden of mostly infectious disease kind of thing, but over a period of time, the chronic diseases have taken up a significant part of the entire disease burden. And at the same time, very correctly, you have mentioned about the elderly senior citizen population, and soon India is going to have, with the increasing life expectancy, the proportion population size of above 65 is also going to touch on a higher side. Now, when we are burdened with so many multiple challenges, I think with the available resources, we need to optimize, and this remote diagnosis and monitoring is going to be solution. And very clearly, you have expressed some of the areas where this can play a very significant role. And just to give you an idea, recently when I was visiting Netherlands, the country has a very small population size in comparison to ours, but there same issue with the increasing of age, with the population, geriatric population in the country, they don't have adequate people to take care of them. They are also implementing many of these solutions to see that how the quality of life can be improved. And Dr. Sanjit, your responses are very pertinent and very well directed towards, I think, where we are leading to. So with this, I move on to my next panelist, that is Mr. Aravind Ganesan, Group Head, Digital Strategy, Kauvery Hospital. Now, when in one side the population has certain expectations, clinicians, they are very clear that what they should get and where it is possible to be, used, these kind of technologies. As a head of digital strategy for a chain of hospitals, question to you that what do you think? What kind of technology platform a hospital should get? The first question comes in everybody's mind. Is it going to be very expensive? Is it going to sit on the top of my existing HIS, existing system? And can I use this very easily? Is it going to increase my cost of healthcare in a significant way? So I think as a technology expert or digital strategy head, my question to you will be, can you throw some light on these aspects of expenses, technology, what you should use? Can it be easily integrated with your existing system and all? So over to Mr. Arvind.
So that I'll break down this problem of really looking at the implementation and the cost thereof into two parts, right? And so there are two aspects to this care. One is a management aspect, which is more about functional medicine, the areas where we have chronic diseases like diabetes management, or let's say chronic kidney disease or cardiac health, etc., etc. This is purely a management function where you have a patient who's going to continuously suffer from this disease. He's at home, and you have to keep a tab on them to see, okay, are they getting better, or are they getting worse, how is their medicine working with them, etc., etc. This is more of a management function which you have to continuously do. So this is probably a problem which has been figured out very well during COVID. Basically, we saw a plethora of companies coming up during COVID, which was selling wearables, putting patients on wearable continuous glucose monitors, and then tracking them through an app. This is actually a very cheap solution to implement also, because most of the variables that you're getting are the evolution path of collecting this data to an information, and from the information getting an insight, and that insight to determine when the next action is mostly human today, and that is where the cost comes right now. So for example, that patient is sending me a sugar data. I needed a diabetologist or endocrinologist to look at this data to say, okay, is the insulin kicking in at the right time? Is the dosage working properly or not? Or do I need to increase the dosage, reduce the dosage, etc., etc. Now, AI will take over at some point, but right now the cost is associated to the human intervention that is required. The technology itself is pretty cheap. So this is the management function of this, and this applies to, let's say, among NCDs. I mean, we do it in our hospital in Bangalore. We've done it for about 700 patients. We've given them continuous glucose monitor and wearables, and we've been able to reduce insulin dosages for about 30% of those patients, right? So it was a very cheap solution to give. So this is the management aspect of it, but this over time, this cost will get cheap. There are a lot of companies that are coming in. So one of them would pretty much crack the overall puzzle of the intelligence of that algorithm, and probably will reduce the human intervention and let patients really help themselves in the situation, and the cost might grow low. The second part of it, the critical care aspect of it, where this is more of a cure function rather than a management function, the capex is very high today. And that is primarily because of the fact that you have multiple different brands which are connected within an ICU, let's say for a patient, right? I mean, so Dr. Swapnil talked about a cluster hospital. So within a cluster hospital, there are 10 or 12 ICU beds, and patients coming up with different illnesses. You will have devices from different brands, right? And each of these brands has its own data transfer protocol. Okay, they have a way of managing their own data, right? Some of them do not even give access to the data. Okay, and we do have healthcare data intelligence protocols established, but a lot of device manufacturers do not follow that, right? So it requires a lot of upfront cost to really integrate these devices into our HIS and into creating a system which allows our critical care doctor to look at the patients in real time. And our internet infrastructure is getting better, but it's not at the point where we are able to give this data at a very low latency. Like within 5 seconds, if let's say heart rate changes, or within 5 seconds if the BP increases, is the doctor able to get that data within 5 seconds and look at this and make an intervention? So those communication infrastructure is still evolving. So there are a few companies which have figured out this. They have implemented it in a small scale in a particular hospital where there has been a good infrastructure, good internet bandwidth, and stuff like that. But are we able to scale it across India to tier 3 centers where there are not enough specialists? The infrastructure piece of it still has some work to be done, and especially in terms of integration, in terms of the internet bandwidth, etc. There is still some work to be done. We're doing some pilots here and there, but we are still getting the latencies figures are not up to the mark. I mean, they are still good enough to really work on them, but it is not good enough that it is real time. So those are the things that we need to really sort out. But once we are able to do that, I think the problem of access would be solved in the curative function also, because that is where the latency and the access to the patient in an immediate basis is much more required rather than the management function, where we can live with some errors, live with some slowness, etc., etc. So that is where we are. The integration with HIS is not a very difficult thing. It's a software problem, and the software problems are all solvable. I mean, it's a very simple software problem to solve right now. And so the infrastructure pieces are the bigger problems to solve, and that is where I think we are kind of in the journey right now.
I think you're very clear in terms of there is expenses, there are challenges to integrate, but still those are manageable. But one of the very important point, what will be my second question to you in the next round, is on your data protection, data privacy, on that part of it, because we are going to be vulnerable when we have so much of this kind of remote management and monitoring system in place. So I'll move on with my second round of questions. And before that, I want to tell viewers that if you have any question, please put it in the chat box so we can take up after the second round before we close this interesting discussion. Now, my question to Dr. Swapnil, that in your hospital, you may have taken up some of the applications related to this discussion point. And my question to you will be, can you talk about some of the successful implementation of this remote diagnosis and monitoring kind of projects, and what kind of success you have seen at the end of it? Try to be a little brief because we are running short of time, but we'll be happy to hear from you about your experience.
So definitely, when we are dealing with, I'm right now working with Fortis Navi Mumbai. So we don't have our setup. In previous setup, I was with another hospital. There I was one of the integral part of this remote ICU monitoring system. And there we always used to have all the data and all our monitoring. We are starting from the admission, and obviously routine whatever history taking and all those things we had executed at ground level with the help of ground staff. Now, in that case, again, the decision making and aggressive nature of our ICU was carried forward to that particular remote center, and obviously we could save the time in decision making and communication and transportation. So we definitely have a good run in terms of running the patients. Now, I will say one of the patient was very bad, and after giving this aggressive nature of therapy in terms of ventilation and dialysis, in terms of higher antibiotics, everything, the case was ARDS sepsis. We did all the protocols, we did all the management, including septic shock. But after 7 or on day 8, patient was succumbed, and we couldn't save the patient. So in that case, the problem was the relative asked for the compensation that our patient was mismanaged. So in that case, legal issues were there, and we followed the 2020 guidelines, which were based on temporary basis, which were made to tackle the epidemic situation of COVID. But in that case too, our court or our legalities didn't show anything to have all the responsibilities to be to be held on this tertiary center. In fact, it was all communicated on paper to start with the ground hospital, and everything was conveyed on paper with the proper signing part with the relatives. So in that case, the case didn't stand, but we learned that it is a very important thing to go ahead with the medical legal clarity, which we followed, and we every hospital was saved. Obviously, I have not taken name of any hospital, but that was the case I learned. Other than that, I would say lots of patients were getting benefited with that remote monitoring system, in spite of knowing that it is not going to be covered in insurance, and patient and relatives has to pay all these extra expenses from their pocket. Still, relatives and patient were happy, and the result, whatever we enjoyed with a good run, the particularly itself remote hospital was also happy. So that was the conclusion. That's the conclusion, that it's a very good opportunistic system, and in a future oriented approach, always it is going to be benefited. Now here, one of the logistics, that is HL7, is something that is health level 7 standards for the interoperability and data exchange, including confidentiality, were maintained in all these systems. So after application of this HL7 with the some subscription model of that hospital, I mean to say a particular ICU may be of 10 bed, 15 bed, 5 beds, but hospital or that particular tertiary hospital always have a choice of subscription of particular beds. I mean 1 bed, 2 bed, 3 beds, and that 3 beds or 2 beds we are managing on our remote center. That was the plan, and we executed it. So ultimately, this is a very futuristic approach, and it is very, very important to go ahead to strengthen our peripheral healthcare system, and to gather all the data whenever it is possible. And definitely any meta-analysis or studies is needed for further exploration and for further betterment.
Thank you, Dr. Swapnil, and thanks for sharing some of these successful cases what you have personally handled. And you mentioned about this futuristic approach, and I'm sure it is not going to remain any more futuristic, because people are going to embrace this new kind of advancement. With this, I move on to Dr. Sanjith, and my question I'll take up where Dr. Swapnil has ended. He mentioned about cost, he mentioned about getting this success. So the question to you, you have different stakeholders to handle. In one hand, you have patients, on the other hand, you have hospital management. So do you feel the cost, what you need to incur to set it up, whether hospital administration management, they are ready to invest in this kind of futuristic thing? Do you think that patients, they understand the possible benefit what they can garner out of this, and are they ready to pay anything extra for this kind of advanced modalities, which can add lot of values than what they are getting today? Over to Dr. Sanjit.
Yeah, thank you, Dr. Joy. And I think there is no doubt about it that the administration is always pro-patient. There is always pro-patient. So there is, never a problem, provided you put the solution very clearly in their mind as to why we need something like this. As I speak today, just now, actually, I have remote monitoring happening on my phone. If you see this, there's remote monitoring happening on my phone. So anytime I am there, I am able to actually speak. I am able to see the patient at any given moment. I am able to see the entire monitor of each patient at home. So at the end of the day, the administration is very happy that I'm on top of it. So, for example, if there is some patient admitted and not doing well, I am remotely monitoring the waveforms of these patients, the ventilator waveforms of these patients, the ECG, the arrhythmia. So the hospital is very happy that I'm on the job all the time. Of course, my family may not be very happy because it's always on my phone. But otherwise, the hospital is very happy that Dr. Sanjith is always on the lookout. And in fact, that is a selling point. They actually tell the patient's relatives that, the doctor is always on phone. And mind you, when I actually talk to my patients, when I'm counseling them, I actually keep their monitor on. So they are so happy to see that, I am monitoring their patient 24/7. They're so happy to see that. So I tell them your existing pulse rate is so and so, your existing BP is now so and so. They go and see their patient is exactly the same monitor that I'm talking about. So they are actually getting that confidence that my critically ill patient is being monitored by my doctor. So patients are never a problem. It is always the mindset of how we should talk to these patients, and they are ready to take up this. Most of our patients now are Mediclaim patients. They are all in the high affording bracket. They can easily afford these. As Dr. Ganesan said, it is not something that is problematic. Very, very cheap. In fact, the implementation of this remote monitoring that I have has been really cheap, and it has been taken by the administration without a problem. I just had to tell them about the importance of it. Similarly, when you see simple devices like this small device that I have, I'm not actually showing it off, but it's a small device that is which I give to our patient, which is costing 2,000 rupees. What is 2,000 rupees in place of 10 lakh rupees that they pay in the ICU? I mean, that goes to this patient's home. And recently also we had a patient who called me up saying that I'm not feeling well. I just told them to put their hand on that. They found an arrhythmia. Patient was shifted to the hospital. We averted a disaster on this patient. He came to the hospital. We gave him medicines. His arrhythmia went off and he did well. So at the end of the day, I don't think the administration has a problem in setting up a remote monitoring system, because at the end of the day, it is something that is going to benefit their patients, and the cost for this is not very, very high. As Ganesan clearly mentioned, the cost is not high compared to the amount of money that they are spending. The second thing is, are patients happy doing it? Yes, at this given moment, patients are extremely happy doing it. And in fact, we have got a whole class of patients in the rural area also using this device, which is barely 2,000. They would not want to come to the hospital, the real thing, because it's more expensive to come travel all the way to the hospital and pay the doctor over there, take a physical consult and go back. So for them, this kind of monitoring is the simplest solution for them, which actually saves cost. So at the end of the day, it saves cost for them also. And at the same time, they feel that, okay, there is someone watching for me all the time. So I don't think there are any challenges when it comes to remote patient monitoring and diagnosis, when it comes to using technology among the hospital or in the patient.
Thank you. And I think it is very heartening to know that how patients as well as management, they respond to this. And your first sentence was music to my ears, that management administration is always pro patients and they are ready to do whatever best for them. So with this, I ask the last question of the panel to Mr. Arvind. What I told you, the in terms of the data privacy and the kind of new regulations have come into the picture, how do you safeguard yourself when you want to have this remote diagnosis and monitoring?
Right, sir. So that is a evolving question right now, because when you are subscribing patient to remote patient monitoring, you're actually adding another node to where data can be accessed for a patient, right? For example, if you're giving a watch, so there is an opportunity for someone to get into that watch, and then, I mean, since it's a connected watch, to get the data out of that. If you're connecting them to an external monitor, there is an IoT point that again can be hacked and get the access to, right? Essentially, sir, we need to, when we are going, let's say, I'll talk about the management function again, the variable part of it. We essentially need to ensure that the data is encrypted on rest and on transit, right? And for that, when we are choosing the devices, we are actually subscribing the patients to. There should be a sufficient amount of certification that those devices need to go through in terms of ISO and security certifications that those devices need to go to. I would recommend that we store the data. I mean, even if you are working with the vendor to really implement this technology, I would insist that the hospitals really insist that the data stays with them, which is either on premises in their own data center, or a virtual VPC cloud or a cloud instance, which is their own cloud. So, I mean, it is better not to really distribute this data to a third party, because according to the DPDP, if the third party gets hacked, the liability would still be on the hospital, because we would be the significant data fiduciary, right? That would be one. The second thing is, sir, when we are actually connecting patients to these, the external system should only have an identifier which doesn't have a personal identifiable information. That should still stay with the hospital. So, for example, if you are using UHIDs, if you are using some kind of an ID, that would be better rather than using patients' ABA IDs or patients' names, etc., etc. Keep that within the premises. So, distribute the data in such a way that nobody is able to build the complete information. Privacy is an evolving game, right? I mean, a lot of times people really say that this new innovation has a privacy concern, but every new innovation will have a privacy concern, and because there are enough people who are trying to make use of that opportunity to get access to data. It is just that we need to have some best practices which are stood by for all the systems, that new systems that we implemented, to be applied here. But at the same time, we need to make sure that it is not a hindrance to right in the implementation, but we really just do the basics right in the situation. The things that apply to privacy in a on-premise, non-wearable, non-remote monitoring system also apply to a remote monitoring system. It's just that the attack points have increased because you're using variables and remote patient monitoring. So we need to make sure that we have the safeguards in place for that. I mean, some of the ideas that I've given are some of the things that we can implement to do that. But yeah, this is an evolving space, and we would know more as we really just implement this more. But these are some of the things that we have kind of taken care of to kind of ensure that we are protecting our patients' data in this situation.
I think what you said, that though it is a big challenge, but there are ways to mitigate, handle, navigate the situation. And I'm sure the market, the sector is evolving and reacting slowly but steadily towards this kind of challenges. So with that, we can circumvent the perception of threat from this new regulation, which can indirectly, directly hit our regular operations. So I'm sure a lot of people will take learnings from there. So with this, I'll take permission from Mr. Nagesh to take those two questions what have come in the box. The first question definitely to Mr. Aravind, that how much does it cost to implement a remote monitoring system for a hospital in India? So if you have some ballpark figure you can share.
So, sir, we've been talking about two different solutions, right? So, for example, wearables, as I said, are very, very cheap, right? I mean, the software would be a one-time build. I think depending on which vendor which you work with, I mean, it could vary from, let's say, very cheap as 10 lakhs to about 40 lakhs, right? And that could be just the software component of building. But on a per patient basis, they have to just get a watch and then some kind of subscription that hospitals sell. On the ICU part, the biggest cost would be the integration of each model and make. So, for example, I'll just take a multi-para monitor. The GE has its own model, Philips has its own model, and let's say Mindray has its own model. That's three different type of integrations, because GE would have protected the data in a separate. I mean, they're not all HL7. As Dr. Swapnil was saying, even if they are HL7, they would have an HL7 version which is different from each of them, right? Some models will send an HL7 which would have waveforms, others will not. So you would have to build custom integrations from each of these models. Some of this you can reuse, but others you cannot. So that is the biggest part of the capex. Second is you will have some certain amount of server infrastructure, because you're capturing huge amount of data. Like you're actually capturing every 15 seconds, you're capturing all the vitals for the patient. So I've seen companies, third-party vendors who have been selling these solutions, which says, let's say 4 lakh a bed for one-time implementation and a 10% of AMC every year for that. Others have given, let's say, a per day basis cost, let's say 250 rupees or 300 rupees per bed per day kind of a cost, and then done that. And if you try to do it within your own hospital, and if you try to just build it from the scratch, this could come out very, very cheap also for you. But it is still not less than 1 to 1.5 lakh per bed for first capex type implementation. But that will require significant investment and time from your team to really build this, and over 2-3 years to really do that, actually, to cover all the models that are available in your hospital and in the cluster hospital.
That what kind of return on investment can be accrued from this technology? So one, Aravind can answer. The second, one of the clinicians can tell what is their perception. So maybe in 30 seconds, each one of you can respond to that.
So, sir, I will just cite whatever MD Dr. Manivan says. If you say one life, ROI is infinite. So that is what he says. So that is what I will quote here. But very frankly, ROI on the variable part is quite good. I mean, and it is an improved patient experience that we target. I mean, we're not really looking at ROI when we actually implement this. What happens is that it helps us catch adverse events, and those are very expensive. Typically, if you are not putting a patient on a continuous monitoring. So in that sense, we do not really see ROI on the continuous management, but we see basically what is the cost of adverse event that could be happening, which could lead to readmission and all stuff like that. Right? So we've not really come up with a number on that. For critical care, sir, it's very difficult to measure ROI as of now. It is purely prevention of adverse events again in ICUs and stuff like that. It is a very, very new field. I mean, a lot of hospitals have been doing it, but it is not a systemic solution in India as of now. I mean, so again, we do not have an ROI on that, but again, there are enough life saves that happens. And again, as I said, as RMD says, ROI is infinite in that situation. So that's what I go.
And any clinicians, they want to tell their experience.
Yeah, so I think RBM, I mean remote patient monitoring, it aligns perfectly with the goals of value-based care. Actually, it's perfect when it comes to value-based care, which emphasizes on patient outcomes as Ganesan specified. So patient outcomes is always better than service volume. So when you look at that, when the patient outcomes gets better, that is itself a return of investment because your patient is the one that actually sends the next patient. So that's how the return of investment comes back because it streamlines a lot of things that comes into this. We don't want a patient not feeling well. We want a patient to actually feel well when he goes home. So when he starts feeling well at home, he's monitored well. I think this return of investment, that's why aligns perfectly with value-based care. I think that's the ultimate point and it will definitely suitable for any administration to take this up.
So thank you, Dr. Sanjith. And I think you have used a very favorite word of mine, value-based healthcare. And one of my teacher, Michael Porter, wrote a book on value in healthcare, where he summed up very nicely that instead of looking at every episodic care cost, you should take the entire lifespan of the patient, and then you can see that in that complete horizon, the kind of interventions you are making, the kind of quality outcomes you are getting. If you divide by that, then you can get the real value. And probably this, this diagnosis and early intervention through remote monitoring can add value very significantly in our healthcare delivery system. And that is going to be the future need of the hour. So with this, I want to thank all the panelists. I want to thank Mr. Nagesh and Healthcare Radius for giving me this opportunity. And we had an excellent discussion, deliberations, a lot of learning for me too. So with this, I hand over to Mr. Nagesh.
Thank you, Joy, and thank you all the panel members. It has all really been a very insightful discussion today. And the last, towards the end, in fact, the comments that we received about life is the value, the patient outcome is the best value. I thank all the panel members. I thank Joy for moderating the event. Thank you, Dr. Sanjeev, Dr. Swapnil, and Dr. Aravind for providing your deep insights and perspectives and sharing your experience during this session. Big thank you to all the people who joined this webinar to make it successful, and thank you for the questions that you all also asked. Those, by the way, who missed today's session, you do not need to feel bad. This webinar is going to be being recorded and will be uploaded to Healthcare Radius YouTube channel very soon. So thank you everyone on behalf of Healthcare Radius and ITP Media India.